I'll invite Linda to come on up, and the other panelists would come on up and take your seats. We'll begin the process of getting educated on a very complex topic. So thank you. I'm your staff. You're a wonderful partner.
Well, good afternoon, everyone. My name is Linda Heeman-Bach. I'm the Vice President of Business Development for Dynamic Corporate Solutions, which is a full-service human resources company, and Idea Staffing, which is a recruiting organization. And if not on a weekly basis, a daily basis over the last couple of years, we get calls from clients all the time about the Affordable Health Care Act and how it affects their business and their decisions that they make. So we're excited today to have three very distinguished panelists with us. And what we're going to do is we're going to give each one of them about 3 to 5 minutes to talk about the Affordable Health Care Act and their perspective. And then we will open up to questions. So we're going to start with Kyle Sanders, the president of St. Vincent Southside.
Thank you. The Affordable Care Act has been repealed, so I really don't know that there's. I'm kidding. One of the things with, I think, to be honest, or to be, I guess, prejudiced a little bit, the healthcare industry benefits, greatly from the passing of the Affordable Care Act. And there's a lot of controversy with business owners. There's a lot of controversy politically about that. And there are many, many, many things that healthcare industry and healthcare providers dislike about the Act, as all of us do of virtually any law that is passed. But I think one of the things to emphasize that we are attempting to take advantage of is that there were some wonderful things that were written into the bill that have allowed us to participate in some new innovative ways that we're delivering care. Some of those include working on a bundled payment initiative that we're doing at St. Vincent's, and I can talk for 1 second about that, as well as the Affordable Care Accountable Care Organizations. And we're participating. We have the first one led by a hospital here within the Jacksonville market. And really what they amount to is, in the old way of delivering care, which is still the majority of the way that we do today, providers are incentivized to do more. The more patients are sick, the more surgeries that we provide, the more of anything that we provide, the more money we make. The money flows according to the way that we do things. And hopefully people are honest, there's checks and balances that are in place, but really the flow of money and the incentives and the taking care of the whole of a patient, a holistic approach, have not been there historically. These new innovative ways of delivering care give us the opportunity to learn how to transition the way we do care. Maybe actually create a way where hospitals and managed care companies or any employer group or doctors or post-acute care providers actually talk to each other about what's going on with that patient and making decisions about what's in the best interest of that patient. And then, in fact, being paid adequately to do that. I think that's one of the greatest things that's come about from the Act. So we're participating with bundle payment. I give you an example where we're doing one for total joint replacement, knees and hips. And one of the things that we discovered when we were looking at that, within Jacksonville and within our own system, 84% of our patients went to a skilled nursing facility following a joint replacement. Around the country, the average was around, give or take, 50%. And it's not that a patient doesn't benefit from that, but did they need to go? Were they well enough that they could have gone home and either maybe seen a home health provider, or even better, gone home and then gone to outpatient rehab so that they can get to their best functional capability? Not only is that in the best interest of the patient, that is in the best interest of whomever's money we're spending, whether that's Medicare through CMS, whether that's Florida Blue, whether that's anybody. It's doing the best thing for the patient and at the same time doing the best thing and being a steward of the money that we've been entrusted to take care of that patient. Today, as we've started that, and believe it or not, we started January 1, we are now at less than 50%. We're hovering just a little over 40% of our patients are going to skilled nursing. And again, setting clinical criteria, working with our physicians, working with our post-acute providers to say, what's the best place to do that? So lots and lots of transition of care things that are going on. And I think from the Affordable Care Act, There's money that CMS has put into those that have allowed us to change the way we deliver care in the best interest of the patient and do so in a way that doesn't hurt the providers or even provides them the ability to be able to pay adequately for their services. So some of those innovative approaches, I know others are going to talk about, working, with one of my other panels with Florida, some of the exchange products that are out there and available for employer groups. It's been very difficult for small employers to be able to always afford or be able to go to the market to get insurance. And there's some really great strategies that have been out there, and I won't touch on those, but that's one of the other things that we're seeing. We've partnered with them to be able to bring to the market. And the tax advantages of those are just wonderful. So lots of problems with the employer reporting capabilities that we've got to get to. We're a large employer, and it's just killing some of the reporting things. So there are many things about the bills that are frustrating, and I won't get into the politics of should we or shouldn't we, but we're really trying to take advantage of those things that are going to help us improve the care that we deliver to the community.
Okay. Thank you, Kyle. Next, we have Representative Travis Cummings, and I think he's going to speak today in his capacity with Bailey Group. So, Travis.
Sure, and remind me of the original question. I was so, I like that Kyle with me because everybody in the room knows me like, yeah, somebody talks so much as Travis does.
Yeah. Well, and I got the hook, Travis,
yeah,
so
right.
I didn't really pose a question as much
kind
as,
of an intro.
yeah, just kind of an overview.
He's saying let's get the money for it. But no, thank you. And, I would just say a couple things as I see one of our Bailey Group clients in the room with Brooks, and I see one of my Hawk Financial clients with Drew at Council on Aging is something exciting on kind of a little self-promotion here is we've rolling up Hawk Financial under the Bailey Group in the coming months. The Bailey Group services about over 300 employers in our state, primarily Northeast Florida. And then Hawk Financial is about 50 or 60, and so it's a nice merger of the two and gives us a lot of depth and resources and expertise that we all know we need as you navigate through the Affordable Care Act and so forth. So that's exciting for all of us. Speaking from the, I'll touch a little bit on the legislative side, although at the state level, much of the mandates for the Affordable Care Act compliance is such that it's done on the federal level. We've opted for the federal exchange that has been built before, which most states did, by the way, whether you were a Democratic-led legislature or a Republican-led legislature throughout our country. Most went with the federal exchange, and it's worked out for the most part in terms of not only the state not being burdened with its costs, but the functionality after the initial delays. I will say that from my professional life as it relates to consulting with employee benefit services, we have a sizable individual health, and we're a partner with CGA, they call it, with Florida Blue and a lot of individual health, which is one of the attractions of the Bailey Group. We have two individuals with us today, both Heidi and Judy, and I know that between the time the exchange opened versus to the end of the enrollment period, there's nearly 1,000 policies that we wrote. What we saw was clearly most folks, and to me this is the only reason you would really go to healthcare.gov, is if you qualify for a subsidy. In Florida Blue, I know has left some great things here on your tables, and I know that Kelly will get to that in a minute. And those subsidies can range to where someone that's making under $20,000 a year may pay $40 or $50 in some cases a monthly premium for health insurance. And so obviously that's shut down now, unless you have, we'll get into that maybe in some of the questions, but on when you're eligible to now do it versus waiting on the next enrollment. And that's been a little bit tied to our hands. We hope the feds will look at changing that a little bit because now there's some limitations on people that can purchase insurance. There's no doubt that the access to health care, quality health care has increased as it relates to the Affordable Care Act. No one, I think, doubts that. Some measures from efficiencies and cost control or containment clearly have been identified with ACOs that one of y'all may get into and some other things. The cost, however, for the employer or even the individual, if you're not getting a subsidy at healthcare.gov or in the exchange, it's not like you're the healthcare premiums or the rates went down any for the most part. Nothing against Florida Blue or your other major carriers, but healthcare trend, which you'll hear Kelly mentioned, which is inflation, that continues now to kind of creep back up in some cases double digits due to recession when utilization decreased. We saw that go down to some record levels, which was great. And so some of the increases to employers was minimized some. We saw some flat increases, which people couldn't believe that the owners were glad to accept it. We saw some negative renewals, which you would never hear about, particularly if you shop the marketplace. Now we're back to seeing the double-digit increases more common. Many times when you get that, I wouldn't want to ever say you earn it, but it's due to just some poor claims experience within your group. But you start factoring in the ACA taxes and fees as well as medical trend. You throw those together, you're at 10, 15, 18% in many cases, and that's notwithstanding the claims. And so from the employer's end, we're just continuing to see challenges and being able to continue to provide health care. We try to do everything we can with creative solutions, with wellness and other things, and working with our carrier partners. But it's a challenge. But we embrace it, irrespective of what we think wholly about the Affordable Care Act, and we have prepared ourselves and made sure we obtained all the resources. But it's a work in progress. Rules continue to change and get interpreted, and it's our job to pass them on to our employer partners and clients and work deals with them. But thanks for having me here today. And Kelly's up next, right?
Absolutely. And we have with us Kelly James, and he's with Florida Blue.
Good afternoon, and thank you for the opportunity to speak to you this afternoon. I'll touch a little bit on some of what Kyle and Travis have already mentioned in terms of the Affordable Care Act. It does represent the most significant change to the healthcare industry since the Medicare and Medicaid programs were established back in 1965. And if you think about it, those programs have been in place now for almost 50 years, and they are tweaked every year in some form or fashion. So this last 6 to 8 months of rollout of the marketplace to accommodate the Affordable Care Act really should be expected. All of this is not going to be resolved in that sort of a window of time. This is going to be a gradual shift from the previous way that health insurance was sold into this new marketplace. I know today's topic is primarily about the subsidies and the advanced premium tax credits, and we'll talk about those because those are very important incentives, as Kyle mentioned, for individuals to go out into the marketplace and obtain health care coverage. They are income-based, but taking those, and I refer to them as advanced premium tax credits, not only because that's how they're defined in the law, but to reinforce on people that there are tax consequences related to accepting that financial assistance from the government. You are projecting as an individual what your income is going to be for the next calendar year in order to qualify for that financial assistance. And then when you file your taxes for that calendar year, you do a reconciliation of what you projected versus what you actually earned. And if your projections were off, then there are some potential tax liabilities if you got more of a tax credit than you should have gotten. On the other side, if you did not get enough of a tax credit because you overestimated your income, then you'll get some additional tax credit back. So that is one thing that we have seen as not having been fully explained to consumers going through the marketplace and looking at the availability of that financial assistance. There's also some responsibility on those individuals to make sure that their financial information is as accurate as possible, because those decisions about their qualifications for those tax credits is based on that household income. It needs to be as accurate as possible to prevent some of those tax consequences. The other thing that we're seeing from our experience in dealing with consumers coming into the market is everyone is fixated on how much of that subsidy they can get to offset that monthly premium. And they are not looking at the specific cost share responsibilities and the plans that they are selecting. There are people based on their subsidy that might qualify for a bronze plan in the marketplace where they pay $0 premiums every month because their subsidy offsets the entire cost of that premium. But then when they show up at St. Vincent's to receive care, and St. Vincent's tells them, well, you have a $6,000 deductible that you have to meet before your plan benefits kick in, then the frustration begins. And so what we are talking to consumers about around the state is think of health insurance more of a total cost of ownership, like a car. You pay for gas, you pay your monthly note to your lender, you pay for car insurance, you pay for repairs. So when you're looking at health insurance, look at not just the premium, but what are those cost shares, the deductibles, the out-of-pocket expenses you have to cover over the course of that year, average it out over the course of that 12 months, and maybe paying up $20 a month for that silver plan that includes some of those back-end subsidies called cost-sharing reduction that knocks your deductible down from $6,000 to $600. When you look at that math over the course of 12 months, you may come out cheaper actually buying up into one of those silver plans based on your income. So that's some of the things that we're trying to figure out. How do we get more of that information into the hands of consumers so they can make better informed decisions?
Thank you, Kelly. So I think a lot of the folks here today are employers, and they're making decisions about whether people are working full-time, part-time, how many employees they have. A quick question would be, what would be your suggestion about, how they determine how they develop their workforce and the retention of their workforce as an employer and as it relates to any health care or insurance that they provide?
I guess my first question would be whether you are a large employer or a small employer as defined by the law. The law requires employers to count not just all their full-time employees, and the law defines full-time employees as those who work 30 hours or more per week, not 40. The threshold is 30. You have to count all of those people, and then you have to count all the hours worked by your seasonal or part-time staff. Add those up every month of the calendar year, divide that number by 120, you do that for every month of the year, divide those 12 results by 12, and then if your number is higher than 50, you're a full-time employer under the law, and you're subject to some of those penalties about offering coverage and making sure it provides minimum value and meets affordability criteria. If you are a small employer after you go through that exercise, then nothing in the law requires you to offer insurance to your employees. You are not penalized if you don't offer insurance, and if you do, then there are very specific types of plans you have to offer that meet specific benefit requirements in terms of covering essential health benefits. The deductible limits for small group plans have been eliminated, but you'll have a multitude of options available to you as a small employer. So it really comes down to, as an employer, what do you value in terms of your overall compensation package as the role of health insurance, and how much can you contribute toward that? Is that something that you need to attract and retain employees, or are your employees better off based on their income levels going into the marketplace by themselves, qualifying for a tax credit based on their income, and making an individual decision about their coverage?
I think to add on that, I would say from the employer level, I know with our clients, many of them were, most of them priority compliant. And what I mean by that, a lot of them are either full-time employees or none. It was it. They just had 40 hours a week or 35, and they weren't impacted by that. So their objectives were to make sure it was affordable, what they were offering. We, as their consulting firm, have tools to measure the 9.5% of the premiums cannot exceed that for part of their gross income. And most were even okay with that. The carrier partners already ensure that compliant plans are being offered, and they can work it through to make sure that it meets the actuarial value numbers as it relates to the Affordable Care Act. The challenges are, for instance, where we're at here today at the Holiday Inn is a client, and they have 6 hotels, and so what does that mean? They have a lot of those groups were management carve-outs. They only offer the hospitality industry, your restaurant industry only offer benefits to either salaried folks or managers. Well, now they're the threshold, whether it be housekeepers or maintenance staff or folks in the kitchen, they have to be offered benefits for 30 more hours. Well, all those people for 30 more hours, and so they just had to make fundamental decisions to decide, well, that's a huge expense for them, so how do they still effectively operate their business and have it staffed adequately with people if they just cram them all down to below 30 hours, which unfortunately wasn't the intention of the law. Now those people are making less wages, so they either got to get another part-time job or something of that. But it clearly has had a tremendous impact. On top of that, folks like us have gotten those employers ready, but then the delay, employer mandate has been delayed. For those that are 51 to 100, it's 2016. For those over 100 employees, it's 2015. and so that has been complicated. I know that not to toot our horn in our profession, but clearly most employers have a consultant, a broker, an agent. Y'all figuring out real quick if they're up to speed on this, if they need to be. That's who I would always consult with and make sure that they can work with you through this. I know some folks it may be a little out on the horizon, but there's no problem with planning that and so forth. The individual, plans as well to decide what plan is best for you as you relocate the same way is good to evaluate that accordingly. So it's difficult, but employers are continuing to struggle with them, but most continue to value the benefit of offering employees or value their employees to offering benefits. So we haven't seen anybody that has done away with offering benefits to their employees as of yet.
I don't know what that. I mean,
as a large employer, have you seen shifts in maybe some of your employees having their spouses or dependents who now it's less affordable for them to have the care or the insurance through their other employers? Are you seeing a shift of employees bringing their dependents and folks onto your plans? Or?
We are not so far. What we have, again, for us as an employer, and again, within healthcare, most large employers and most groups were already, to address this point, they were already doing this. They were already providing insurance. They were already providing coverage. It's as you said, it's a strategic decision you make within your employee base, and are you going to be able to attract and retain those employees to keep them? We have made differential decisions about, are we going to charge a premium? We did not. We actually looked at one of the things we did. We increased ours where we charge a premium to a spouse to come on to ours if they have an option to be able to get that at their employer. For those that don't have that option, then it was the same benefit plan that we had always had. So for us as a large employer, on the employer side of that, the biggest thing that we've seen is that was controversial. I mean, that was difficult as we look at our own healthcare benefit plans. But again, we're self-insured, so it comes straight out, of our bottom line whenever we actually have claims that come out. So we wanted to make sure that people were taking advantage of those opportunities through their own employers. But for the most part, there hasn't been anything large as far as percentages. It's been more onesie-twosies that are here and there of spouses and children coming and going.
And that's an important point. If you are an employer, and that's a good point that Kyle brings up about the requirement to offer coverage to dependents for large employers. It applies to all dependent children age 26 and under, but it does not apply to spouses. And so that's a very distinct difference in the law, where the example that Kyle talked about, UPS for calendar year 2014 updated their own health benefit offering to exclude coverage for spouses who had access through their own employer's healthcare coverage. So that is something we have started to see more of. It's a cost control measure. But back to Travis's point, you need to be working with a consultant who understands all these little idiosyncrasies in the law, because there are lots of places to get tripped up as an employer in terms of how you structure your health benefit program.
Yeah, that's the only other thing I was going to add. I mean, again, it's just reiterate. I can't emphasize enough using a consultant. I mean, somebody that, that's what they live and breathe, and I know Travis more than once has read the entire 2,000 pages of the bill and really gets excited about that. But it's that bad. I mean, it's that profound. But going to that point to help you talk about the things Kelly was talking about, because it makes a difference which of those plans you choose, because it does make a difference in your coverage. You've got to not just look at that premium and then you're a healthy person and you go in and you show up, but if you're somebody who does have some disease process that you utilize, you may want to take advantage of paying up a little bit, because where many people, if they're at that level, where are they going to come up with the $6,000 or the $10,000 deductible every time instead of planning that in their monthly budget?
And what about, that you hear a lot about supplemental plans and things like through Aflac and other companies like that to offset some of the expenses. And what are briefly each of your thoughts on offering some of those things?
I would say obviously your Aflacs and Allstates and Colonials and all those in that space. We're seeing group carriers like Lincoln Financial and some get into that. Aflac is still clearly the market leader and does a great job, particularly in adjudication of claims. But those are still there. They're very prevalent. There's still a cost to them. I haven't necessarily seen those costs go down, but they truly are meant to supplement whatever core group benefits you have, whether it be medical or whether it be dental or disability or life or whatever. But we are seeing gap plans a little bit more, where they were a little more restricted to larger employers, that it can help provide some dollars with these high out-of-pocket or high deductibles or sometimes even high co-pays. So they're clearly, with the Affordable Care Act, not to speak directly for them, I know we have one Aflac rep in the room, but I don't know, while there was probably some compliance measures as it relates to their products and plans, they were largely not impacted like all of us at this table and employers were, and so clearly it's a solution out there that we're continuing to see more and more. What we're seeing as well is self-funded candidates that is going down in terms of ratcheting the threshold. Used to, it was unheard of to be over, if you're under 1,000 people, it was self-funded. Now then it was maybe 700 or 800, maybe 500. We actually are going through analysis. We have a self-funded team at the Bailey Groups. All they do is looking at employers under 500 in some cases, 300, 400. You get out of some of the, I wouldn't say get out the right word, but you definitely avoid some of the burdens of the Affordable Care Act, and you have more control that way. So we're seeing partially self-funded or self-funded solutions for employers be evaluated more for even employers that are in that 200 to 500 space.
And just to add a little bit to the discussion on indemnity and supplemental plans, we are seeing rules in the process of being developed that are essentially going to restrict the sale of those types of plans to people who already have qualifying health coverage. So the intent is to eliminate the use of those plans in and of themselves as people's health insurance. So the types of policies that pay X number of dollars per day based on treatment of a condition. We're starting to see some rules be crafted that will restrict the sale of those policies and limit them to only those people who can document they have qualifying essential health coverage as a precursor to buying those plans. So that's just another change to the insurance market coming forward.
Well, we appreciate your time today. We have probably about a minute or two, so we can maybe field one or two questions. By the way, I didn't know we had an Aflac rep in the room, so that wasn't a plug. Any questions for our panel?
How do you interact? We have a large retired military community. For example, I made the assumption my two daughters are good till age 26. That in fact is not the case for TRICARE. Once they hit 23 and or graduate from post-secondary, whichever occurs first, you're out. I mean, you can go buy like TRICARE Young Adult, but it's just like buying a regular policy. So then you're like, whoa, what's this? You get the phone call, yeah, I got a letter and I'm out. You go into full-blown, so are you dealing with, you got a lot of retired military and kids, and you deal with them in the First Coast region or nationally, pockets of large military population?
I don't know of any specific campaign targeting those individuals because we don't have access to that enrollment information. But in scenarios like yours, certainly if they reached out to either an agent or a Florida Blue retail center around the state, then we could help them understand what type of options those dependents will now have available to them to get insurance. They would qualify for the special enrollment events that Travis mentioned earlier because they are losing access to coverage that they already have. So they qualify to come into the marketplace and obtain a policy during the middle of the year. And then it gets into do they qualify for financial assistance and those types of things.
Well, I would say, Doug, that is interesting. The federal government doing that when the non-TRICARE plans for employers is up to age 26, irrespective of, it's very, very liberal. Used to it would be you had to be a student. It can be now that you're in some cases married. I mean, so you essentially could be on a parent's plan, but then you got to pay for whatever the premium is for children or families coverage. But at age 26, now in Florida, you can even go up to age 30. There's a couple other boxes you have to check. We've looked at that on the state level to try to better mirror the Affordable Care Act. You know, it's hard though because it could look like we're trying to take access away from those people, but it's definitely a contradiction.